Dear friends, it's a great honor and pleasure and a humbling experience for me to start this exciting Rhinologic Week with our masterclass. I'm Valentin Tomasik from Graz, Austria, and on behalf of the whole organizing committee and of the ERS Juniors Board, I'm happy to welcome you here, and I'm also very happy that we could win Professor Andreas Leunig from Munich for this master dissection. He is not only an excellent surgeon and my mentor and the mentor of many young colleagues, but also a good friend, and he will lead us and guide us through the sinuses with a special focus on the frontal sinus. As such, we will have colleagues from the organizing committee around here with microphones, so whenever there is a question, please raise your hand, give the colleagues time to approach you. I will give you a sign then, and then you can ask your question directly, which will be transferred to the Guy's Hospital directly to the dissection table, and then we can go through this in an interactive way so you benefit the most from this master dissection. We are ready to go. Enjoy your time in London. Enjoy the master dissection. I'm happy to be here with you, and I'm happy for a vivid discussion.
Yeah, Professor Valentin. Dear Valentin, dear guests, it's a great honor to be here and to show you this master dissection. So before I start, I would like to introduce the team. And with me are Lizzie, who is assisting me the next 1.5 hours. Thank you very much for your support. I would like to thank the whole STORZ team for all the equipment, for the great work they have done, and as well the people from the Institute of Anatomy here at the Guy campus. The aim of the next 1.5 hours would be to show you the basic principles of nasal endoscopy and the surgical approaches which are possible in case, if it's necessary, you can do during a FES procedure. And there are some important things you have to consider. It's the main setup you should have. When we look at our specimen, the specimen, it's almost the same situation like in our office or in our OR. The patient or the specimen is in a lying position. The head is slightly elevated 30 degrees and turned to the surgeon. And it's important to make in your first step your proper nasal endoscopy. So the main question is, what should we look for? Which kind of endoscope, telescopes you should use, and how to learn or learning to be atraumatic. That's very important. And what we use in the first step is a 0-degree endoscope, which is very helpful to get a good overview about the nasal cavity and the cleft, the openings. And there are 3 passes, three steps you should perform routinely when you do your diagnostic endoscopy as well your surgical procedures. So let's go in with the endoscope and let's show you how we do it. Very important, handling of the endoscope and the camera. When you go in, you should always, and this should be shown you by the outer camera, you should handle your endoscope in this position. You go in very steep and you have a very firm position of your endoscope to be sure having a good overview. So when we go in, please pay attention, keeping your endoscope clean. What do we need else? We don't need trimming hairs. We don't need a speculum. However, in a patient we need anti-fog solution. So now we have, I think, a very nice overview of the nasal cavity when passing the nasal valve. We are watching here the inferior turbinate on the left, the right side we have the septum we are passing through, and we're going to the posterior part. We are coming in the level of the nasopharynx. We are focusing here on Eustachian tube, the Rosenmüller's groove, and even you can look on the other side and watch the Eustachian tube on the other side. So the roof of the nasopharynx almost normal. There's no pathology. A little bit debris, a little bit fluid is here. We can suck it away. Please, a sucker. and we can clean during watching. And this is the first step, the first path you should perform during your nasal endoscopy, and do it very gently. Learn to be atraumatic. The mucosa is your friend. Don't injure the mucosa, otherwise you have already a bleeding. This is influencing your nasal endoscopy. So coming now, retracting a little bit the endoscope brings you in the second position. Now we are here on the level of the posterior third of the middle turbinate, and usually this is the way where there's more space to get into the middle meatus. But before we go in, we go here to the sphenoidmoidal recess. We try gently to push a little bit the middle turbinate laterally to see if there's any view or glimpse into the sphenoid sinus ostium. I cannot see it yet. However, later on we have to find our way through the posterior ethmoid into the sphenoid sinus, and this is what we do a little bit later on. So now coming back, retracting again the endoscope, going into the middle meatus, and now a very beautiful view onto the uncinate process. Here the free margin, please, the FREA. And we are facing here the head of the middle turbinate, which you should not fracture, leave it in place. Just for demonstration's sake, I gently push it a little bit more medially to demonstrate this is uncinate process. This is the anterior wall of the ethmoidal bulla. And going further, we are now looking into the middle meatus, and there's no sign for pathology. And now retracting further the endoscope and trying to get a view into the area of the frontal recess, but usually you cannot see in this situation the natural ostium of the frontal sinus, only if you have a medially bent uncinate process and you would have a 30 or 45 degree endoscope. Sometimes you can look into the frontal sinus. There are some clefts, openings up there, and this is a way up later on to find over the frontal recess into the frontal sinus. So, well, this is very important to begin having an overview, having information about your local situation. Here the septum was a little bit deviated, a high septal deviation. In this situation we used a long speculum just to push it a little bit more to the other side. In a case like this, if this would influence my surgical procedure, I would make a short injection here, and I would take out a little bit of the cartilage, very limited access to this high deviation, and bring it in this position. So, well, the next step is how should we prepare the area where we could do surgery for vasoconstriction. For me, it's a very important step in our surgery, because bleeding means you don't have your orientation, you cannot be very precise, and you grab in blood. You should have a bloodless surgical field. In many cases it's possible, and for this, Lizzie will give me some of my cotton, my swabs. Please give me a swab and bring it here, and I show you how do I do it at home. Okay, go further. Yeah. So now this is my cotton pledge and my swabs, and I place it where I do later on my surgery. Please, the second one. I place it directly in the middle meatus, between middle turbinate, uncinate process, and in front of ethmoidal bulla. And the same is here, the next one. And I use usually 2 to 3 of these. soaked with 1 to 5,000. You can even use 1 to 1,000 adrenaline, but this is only for vasoconstriction topically and not systemically. It's not used for injection. And the side effect would be as well a dilation a little bit without fracturing the middle turbinate. And after waiting 8 to 10 minutes, we take it out. And when you take it out, it should not be bloody, showing that you were or you learned already being atraumatic to the mucosa. So now I would like to show you how do I inject. Please give me the needle. Okay. Upsala. Okay, and what I do is I bend the needle a little bit so I have a better access to the area where I want to inject my local anesthesia and my adrenaline. And when I'm looking up here, that's the axilla of the middle turbinate, here the Aganasi area. Usually I inject here in this area 0.5 mils of 1 to 100,000 adrenaline, and this helps a lot to get less bleeding, to have a good control of the surgical field. So Saka, please, on. So these are the first steps before you go and start your surgical maneuver. It's part of all. For me, very important, be gently, don't injure your mucosa, getting orientation what's going on. And we have a very thin middle turbinate. It's not a conchibulosa. Conchibulosa and sometimes gives you a big advantage by resecting the lateral aspect and getting more space. But here we already have a nice view onto the ethmoidal bulla, uncinate process, Aganasi area. So the next step, and this would be now the surgical procedure, is to identify the uncinate process. Now, my question, Valentin, how to resect the uncinate process? But before you do the uncinectomy, keep in mind, it doesn't mind which way you will resect the uncinate process. Please don't grasp and don't pull mucosa, because this leads to uncontrolled removal of mucosa, and this is what we want to avoid. Please give me the sickle knife. Usually I prefer, besides many of different ways how to resect the uncinate process, I prefer two main ways how to resect the uncinate process. Of course, it depends how are the configuration of the uncinate process. Do you have a medially bent one? Do you have pathology inside? Do you have a hypoplastic maxillary sinus where you have a very close relation between the uncinate process and the orbit? This has to be considered by doing your technique. So choose the right technique in your right patient. It's individualized. It's not a standardized procedure. So now what I'm doing is the most frequent one, the most classical one. I try to find the attachment of the uncinate process by pressing on the uncinate process here. And you see here, it must be around here. Valentino, I hope the picture is fine and it's sharp enough. If not, you have to tell me. And here, this is the line where the uncinate process is inserted at the level of the lacrimal bone, and it's called the so-called lacrimal bulge or maxillary line, and you should never go in front of this line, otherwise you can end up in the orbit and create some orbital complications. So what I try is I try to palpate to see where the insertion must be here. This is one way you could do it. The other way how you could do it, please, the backbiting instrument. So Lisi is doing a fantastic job. We don't know each other, but I think we are getting closer now. And the next...
Andreas?
Yeah?
You mean Closer to each other or closer to the Ansinet?
Aha,
No,
I
just
don't
kidding.
let you know.
I have one question.
Yeah.
There are some points in the endoscopic view, a 3, a 2. Could you briefly explain what those points that are superimposed on the endoscopic image mean?
Yeah, that's the present for all the participants who are, watching the dissection. We are using navigation, and we mark the way up into the frontal sinus, and these are the markers in your endoscope, and they show you up the way. It's a pathway in your endoscope which can guide you in the frontal sinus. But we want to switch it off, Mrs. Hartmann, now. But before we switch it off, we show you how does it look like. I go in with my, I go in with my pointer to show you how does it look like on the picture. Okay, and now we are. Can you see the navigation picture? Can you see where we are, Valentino?
We can see it, yeah, we can see it.
Yeah? Okay, and this can help you later on. Can we show the pathway? Okay, now we switch to the pathway to show you how do we get into the frontal sinus using the endoscopic picture and the pathway which we marked. We have just to switch to this mode. And Mrs. Hartmann from Storch, she is doing here a great job, and it takes a...
Perhaps I just briefly explain to the audience that those marker points should guide you the way up to the frontal, but you, the surgeon, has to put these points into the CT. So the computer doesn't generate it by itself. You can switch it on and off. And before starting the surgery, you look on your CT, on the three-dimensional reconstructions, and then you point out this pathway where you want to have your endoscopes, your instruments go up there. And this is then displayed by the computer in the left lower image. You see here, this pathway is superimposed onto the endoscopic image. And if you follow those rings, going through these rings, they will guide you up to the frontal sinus. And this could be helpful or is helpful in finding your way up there if you want to.
Okay, can you see the pathway going up?
Yes.
And
perfect.
It should guide you, but as you mentioned, I think it's very important. Now we go back again. Please switch it off. It's very important that the surgeon is familiar with the anatomy, that he's able to do it on his own. How I'm using my navigation is it's a additional tool which confirms in some difficult revision cases, and I do mainly revision cases up to now. I don't know why, but I have many of them. They're referred, and for this and the tricky ones, even when you do a drill out median drainage, it's very helpful, and I think you are a bit faster as well, more relaxed during surgery. And the technique is available, and why not using it? Okay, please, can we have the full picture? Yeah? Sorry? Okay, so now I'm going to the first step, to the first surgical step, and this is the infundibulotomy. And what I want to show you, can we have the complete picture? Yeah, the whole one? Yeah, that's it. So now I take the sickle knife, please. So now we're going in and holding your endoscope in the proper position, very important to having a nice overview about the surgical field. And now I try to find my way into the Ansnet process. Here I have to pierce the Ansnet process here. And then after piercing, you go quickly in this sagittal position, and then you make your incision line inferiorly, and you gently pull medially, opening the infundibulum. And after having done this, you can come closer with your endoscope. And in the ideal case, we would find already the natural ostium of the maxillary sinus, and it could be around here. Okay, I don't see nicely in, but this is the infundibulum. Now the next step would be turning around upside down. Your sickle knife, you go higher up, and you make the same incision. You're focusing the axilla of the middle turbinate. You try to reach it. However, you don't touch it. Now going up here, and now I open the infundibulum. Very gently, I clean my endoscope. I want to have a nice picture. No, that's fine, that's fine. I use it in a patient, the Elvis, but not here. Because, okay, so now you see the Ansnepp process consists out of mucosa, a very thin bone, as well inside layer of mucosa. And now we are facing the anterior wall of the ethmoidal bulla, the infundibulum, and when you go further laterally, usually through the hiatus semilunaris into the infundibulum, you will later on come around the corner here to the natural ostium of the maxillary sinus. Now, how to resect the Ansnepp process? What is the next step? Please, this small scissor. I usually take the scissor. You can as well take only the Blakesley. Later on the Blakesley. And now I make an inferior cut of the Ansnepp process. Like this. And I do it under my visual control, under my endoscopic control. For me, the endoscope is the best navigation system because it shows you everything you are doing. And I'm going into the middle meatus. You see, I cannot really see the natural ostium of the maxillary sinus. Why? Because there's a lateral tilt with about 10 to 20 degrees of the ostium, and it's lateral. So later on I will show you how I can look into the ostium of the maxillary sinus. So looking up here, I don't want to affect too much the frontal recess here or this cranial part of the Ansnepp process, and I cut here very gently, trying to get the Ansnepp process, this part gently out. And now please, Blakesley. Now you take your Blakesley gently and you get your specimen, and I show you what I could harvest. And this is Ansnepp process, and you see the grip of my Blakesley, and this is a part of the Ansnepp process. It's not the entire Ansnepp process, but it's a big part of it. So well, this is gone to Lizzie. Now we are coming in again. Now we have a beautiful view into the middle meatus. We have done the infundibulotomy, very simple, I think important, but we still left the lamella of the Ansnepp process. It's the first lamella, and this can help us, guide us later on. So now I switch in the next step to the 45-degree endoscope. I have to switch off the endoscope. So the surgeon is doing here the job. So it's live surgery. I have to change the endoscope. New endoscope, new angulation, a new situation. And we go in and we will see if we can already find or see the natural ostium of the maxillary sinus. And when you go in, I think now you can see it. Valentino, can you see it?
I'm pointing it out. Yeah, it's beautiful.
And I think for me, to do a proper uncinectomy is very important, because Ansnepp process and later on Aganasi are the key areas, the key anatomical areas to open the way to the ethmoid cavity as well, frontal recess, frontal sinus. So, well, we could enlarge a little bit more or remove a bit more side biting instrument. With the side biter, This side, yeah, perfect. So I'm using the side biting instrument just to go in and exposing, not enlarging now, but exposing a bit more the natural ostium of the maxillary sinus. And you see here, there are some small remnants of the Ansnap process, but try not being traumatic, try being atraumatic to the mucosa. Mucosa is your friend. So another question would be, what would you do if you would see a lot pathology and you could not see, Blakesley, the natural ostium of the maxillary sinus? So there are some tricks, tips and tricks. You could use an instrument, you could press on the medial wall of the maxillary sinus and create some bubbles at the level of the natural ostium. And then you would see here some bubbles. And bubbles, as Heinz Stamberger told us for many years, bubbles are your friends, and then you can have a hint where you will find your natural ostium. So this is I think, very precise dissection. As you can see, it's just exposing the natural ostium of the maxillary sinus. So now I will go around. This is the lamella, the first lamella of the Ansnap process, as you can see here. And I'm turning around and I'm trying to look up. And this is the cranial part of the Ansnap process, but we will deal with this a little bit later on. So the next step, switching back to the 0-degree endoscope, will be how to handle the ethmoidal bulla. The ethmoidal bulla is the most constant cell in the sinus system, and usually it's aerated. Sometimes it can be very little and can be non-pneumatized. Sometimes, and especially Munich patients having this, after the Munich Oktoberfest, they could have a medial orbital fracture and the content of the orbit could prolapse into the level of the ethmoidal bulla, and when you go in, you're already in the orbit. So pay attention in patients who are already having previous traumas. So now Kuhn-Spoon, the normal one, the Kuhn curette, this one. Now I'm looking now for the ethmoidal bulla. Here, middle turbinate, frontal recess. The best way how to resect the ethmoidal bulla would be to go in medially, inferiorly, and very gently you go in. Oh, and really, already I can feel there's lumen behind it. And there are different ways how to resect the ethmoidal bulla. You can take a Blakesley while. I am taking the mushroom punch straight forward, please. And this mushroom punch helps you to get access, opening, removal of the anterior wall of the ethmoidal bulla. So, going in, and you are safe because you have lumen, you have space behind this anterior wall of the ethmoidal bulla, and this means there's a big distance to the anterior skull base. Usually the bulla can reach anterior skull base, or there could be a suprabullar recess. You still have space or a kind of a cell, whatever you will like it. Okay, so please cutting while. Now for the remnants of the ethmoidal bulla, the cutting while. This one. No, this one.
Andreas?
Yeah.
Now we beautifully see the medial wall of the bulla. Could you please comment on the importance of looking twice towards the medial wall of the bulla and not leave parts of this part of the bulla behind, because it may cause post-operative stenosis, synesthesia, impaired mucociliary clearance?
Yeah.
Could you please give us a hint on that?
Very important. Sometimes the middle turbinate goes a little bit far laterally, and then maybe you will overlook the medial portion, the medial wall of the ethmoidal bulla, and when you leave it, this could be, because of contact to the middle turbinate, the source of local inflammation or even the reason for mucocilia transport, and this could irritate and being the reason for problems of the patient. So now I'm very gently cutting away under good visualization the remnants of the ethmoidal bulla, and now it's getting more interesting. When do we reach the posterior wall of the ethmoidal bulla? And I'm resecting this here. Please give me the Blakesley. Now we have a space behind the bulla. It's not clear. I cannot tell you 100% if this is really posterior ethmoid or if it's a retrobullar recess. So the posterior wall of the ethmoidal bulla seems to have an opening there. And the ethmoidal bulla here, this is the transition of the ethmoidal bulla into the ground lamella. The ground lamella is, per definition, the attachment of the middle turbinate to the lateral nasal wall. And now gently, what I'm doing here is what I try to avoid, but sometimes it's necessary, of course, to tear out mucosa. So this is what you should avoid, but for demonstration's sake, I think it's allowed to do it. And now I try to clean it a bit more to have a nice situation. And we are still using the 0-degree endoscope, which helps us a lot, getting good orientation. And later on, when we are working up to the skull base, we can do it from anterior to posterior or from back to front. We will see. How can I show you how to come to the frontal recess? So, well, it's an interesting situation. You can see there's a bony structure which is going more posterior, and this could be a retrobullar recess. And behind this structure, I think there should be the posterior ethmoid. So, well, Kuhnspoon, please. Could we have navigation, please? I will show you with the navigation where we are. And the question is always how much to remove? How wide should we open? My answer to you, I don't know, because it depends. It depends on the local anatomy, while the appended Blakesley. It depends on the local anatomy as well on the disease of the patient. So it's always an individualized surgical procedure, and this tearing out of mucosa, you can do it, but usually you should avoid it in doing proper surgery. I do it just to expose a bit more the bony structures. Okay, so getting more overview. Cleaning a bit more. Okay, so now I'm using the navigation. We are going in, and as you can see here, I think we are not really in the posterior ethmoid. I think it's the retrobullar recess going up here, looking where we are. And we are approaching up here already the skull base. And this should be a part of the posterior ethmoid. So now the next step would be to identify the ground lamella. And please, what you should always do, you should use it as a habit. Please tell your resident not resecting the entire ground lamella. And there's a reason for this, because stability of the middle turbinate depends on the ground lamella, and when you resect too much, you always have this floppy lateralized middle turbinate. And this should be really keep in mind and teach to all of your residents. So please, Kuhnspoon. Kuhn spoon. Okay. So now I'm going in. I try to find my way here. That's the horizontal portion of the ground lamellar. And when you go up 2 or 3 millimeters, you can pierce, you can perforate here, and you will end up in the posterior ethmoid. So let's see if we are right. This should be here the space of the posterior ethmoid. Yeah. And I'm gently exposing this area. Okay, there's some more structure here. We're taking this off. Blakesley, please.
Would you orient your instruments always towards medially in order to protect the orbit? Would you recommend this when you pierce through structures?
Yes. I think that's very important, Valentino, just to stay more medially and inferiorly. So sometimes you have an exposed optic nerve or even an internal carotid artery in a so-called Onodi cell or in a sphenoethmoidal cell, and this can, keep you on the safe side. So I take out this mucosa. Sorry, I'm usually don't tearing mucosa. Let's assume this patient has severe inflammation and there's a clear indication to make all the sinuses to open it. You are allowed to do it. So now let's see where we are. That's interesting. There are a lot of cleft space and openings here. Okay, so, well, it's not 100% clear where we are, but to be sure where the ostium of the sphenoid sinus would be, we could use the transnasal route. Please give me the Kuhn spoon. And now we are going in. I bring the middle turbinate a little bit gently more lateral, and now I'm going in the superior meatus and I try to find my way into the sphenoid sinus, and it could be up here, a bit higher up. This seems to be the opening into the sphenoid sinus. Yep, that's where we are. And now I'm coming back. Now I'm not seeing the superior turbinate, which is for me a very important landmark in terms of getting orientation about the natural ostium of the sphenoid sinus. Another helpful anatomical landmark would be the natural ostium of the maxillary sinus, the floor of the orbit. And when you go here and you draw a line, and William Bolger, he was publishing and drawing the so-called Bolger box, and you stay medially and inferiorly. When you have this kind of a box, you will end up in the level of the natural sphenoid sinus ostium. So now let's see where we are. Now I'm piercing here, I'm opening still a part of the ground lamellar. I think we are here on the right way. This is the superior turbinate, which gives us more orientation about the way into the sphenoid sinus. And this here seems to be another cell which we can open. I will take out this mucosa, please, Blakesley. And again, usually don't tear the mucosa. When you tear the mucosa and you injure the nerve or the posterior ethmoidal nerve, there can be very bad neuralgia resulting. So being gently and not being too rude. And now we are going in. We are watching where we are. Okay. So that's the way. Give me the navigation system, please. We are just checking with the navigation system because we have it, where we are and what's the right way. Now let's have a look here. It seems to be that we are already at the level of the anterior wall of the sphenoid sinus. Maybe it's not 100% precise. And this is the way into over the ostium. So the safest way would be here, but you as well can use this anterior wall of the sphenoid sinus. Pay attention on the lateral wall. Here's usually the optic nerve. A little bit lower you have the internal carotid artery, and up there you have here's another cell, but here up there you have the skull base. Okay, please give me the Kuhn spoon. We are going in. Now it seems to be a not very thick bone. Bitte please, Blakesley. And now this is already the mucosa of the sphenoid sinus shining through. And usually I try to find or to combine the opening which are created with the natural ostium. Here I try to open this mucosa. Please, sickle knife.
Why do you combine the both openings?
Because sometimes, I mean, there could be as well a so-called missed ostium, a recirculation phenomenon, and this can be avoided by creating one opening and not like in the most frequent missed ostium sequence in the maxillary sinus. Having a normal mucocilia transport. So now I try to keep the mucosa where it should be, and now before I open it a little bit, I go in. That's a small sphenoid sinus. Please, the olive, the straightforward olive for the sphenoid sinus. Yeah, the small one. Now what we can do, we can expose a bit more this opening, enlarge a little bit more. This would be a type 1, and now we are taking this very nice instrument, just getting up here and cutting it. Don't tear, don't pull, try to be gently. I mean, this is the best training for all of our younger colleagues to be familiar as well for the more difficult cases, but they are more rare. And I think we have to train this kind of treatment concept, and then you are able to do everything else. I think a drill out procedure can be learned very quickly when you learned your proper basic principles. The normal one, the big one. Now we are facing now the sphenoid sinus. We are facing the anterior skull base. Yeah, there are some bony lamellas left. Okay, I cannot take this bone away, but that's fine, should be okay. So now, through cutting Blakesley, now I'm slowly stepping further to the frontal recess, anterior skull base, looking where we have the anterior ethmoidal artery, and usually you don't have to look for the anterior ethmoidal artery. However, it's good to know where it is, and usually this artery comes from the orbit, crossing the skull base, going into the lamina cribrosa and entering the endocranium, as well giving some branches to the septum as well to the middle turbinate. That's why we do this injection, what I showed at the beginning, and it's important to know the run. So, well, looking up here, I'm not sure where we have the anterior ethmoidal artery, but in a second I will switch to another endoscope, to the 45-degree one. And this is my very favorite one. I clean a little bit more. I want for you a nice dissection, nice here situation, Blakesley. And you are facing now the sphenoid sinus. You are coming higher up to the skull base, And now the question is how to approach the frontal sinus. And Valentino, I think this was one of my, or is still one of my major tasks, to show how we should perform the basic or the philosophy of Messerklinger, Heinz Stamberger in the proper way. I think there are different ways how to do frontal sinus surgery. I try to do it not very complicated. I try to do it very easy. I try to navigate by my present anatomy. So I try to have a good view, a clear view into the frontal recess. And when we are looking up, I'm not sure which opening, which cleft is the right way in the frontal sinus. But now let's show you in a second, please, the Kuhnspoon, the upbended. When I'm going out, I clean my endoscope. No, the upbended one. And now it's helpful. Why did I leave some remnants of the Ansnap process? It's up here. And this is a part of the Ansnap process. And now let's have a look here. It seems to be, this could be a kind of a blind recess, a so-called terminal recess, the Giraffe. Now I try to clean it. I do it step by step. I come from the ground floor to the first floor, and then I come in the second floor. And this is Ansnap process, as I said to you, for me very important structure, because when you understand the anatomy and the fusion maybe with the Aganasi area, and you know how to open it and which technique you can use, it can be very helpful to give you space, to give you access. And now, okay, very nice, beautiful. I think complex. It's not a very easy situation. Valentino, what do you think? What's the right way into the frontal sinus? I cannot tell you, but maybe we can have the navigation system just to see. And what I want to do, I want to look around the corner. When you see here, that's a terminal recess. Maybe there's another cell. It could be a cell. It could be maybe Aganasi. And this here
Perhaps
could...
ask the audience.
Oh, yeah,
Perhaps
okay.
ask the audience.
Yeah.
So who is for the left opening? Raise your hands.
Navigation.
Who is for the middle opening? Raise your hands.
Do we have the upended?
So
Yeah.
a couple of people are for the middle opening, and who is for the right opening?
Indeed.
Oh, the majority of people are for the right opening. And those who didn't raise their hands would stop, or what would you do? Would you take navigation? Go for the CT, yeah, look for the CT. So the majority would go for the right opening of those three, so I'm curious of what way you will choose.
Okay, I saw. Okay, which one is the right one? This one?
No, not as if we take the votes from the
Okay.
audience.
So the right one would be here?
Yeah.
Okay, I'm not sure. Have a look here. When you look at the navigation, the question is the navigation really precise? This could be in sometimes a little bit a irritation, but I think we have as well the endoscope and we have anatomy for navigation, and as we can look around, there seems to be a wide opening up here medially. And now what would be the next step? First of all, I try to find the anterior ethmoidal artery, and it could be here, around here. So I would resect this part of the bone here, exposing much more the cell. And then I go and take this medial wall of this cell, and then step by step approaching by using the upbended instruments the frontal sinus. So
Could we just ask you to point on the ethmoidal artery again to show this
Yeah.
little
Please,
notch that we
navigation.
are always taught would be the route from the orbit towards the intracranium to identify it, whether it's below skull base or in skull base?
Okay, so yeah, I think that's it. That must be the anterior ethmoidal artery. So I think we could be a bit more precise, but I'm quite happy because I see I have my orientation. And what I'm doing now is I go in with my Kuhn spoon, please, the upbended one.
We also have a question from the audience.
Yeah.
Hi, Mariola Zagor from Warsaw University Hospital.
Hello.
May I ask you, how would you name the middle cell? Suprabular cell?
Yeah, it's a good question. I mean, when this would be the terminal recess here, so the lateral insertion of the Ansnap process at the level of the lamina papyracea, and this would be another cell which is higher up. It could be the Aganasi area because this is the next cell. If this would be the Aganasi, a small cell, this would be a so-called supra-aga cell. If this would be a cell which is protruding into the frontal sinus, this would be called a supra-aga frontal cell. So it depends, and you have to be sure where you are. And I think what I see, this is a terminal recess. This is another cell and could be Aganasi. So I think this is a Aganasi cell. Yeah. Okay, please give me the olive. It's a very big cell. Usually the the upbended one. The supra-aga cells, or former called Kuhn cells. No, the upbended. The former called Kuhn cells are a bit smaller, and this is a very big cell. But let's see. So now I try to resect this here to expose it a bit more. And again, being gently to your mucosa. Mucosa is your friend. There's no reason to denote bone too much. Otherwise, you have secondary wound healing, you have crusting, you have restenosis. And this is exactly what we want to avoid. I mean, I'm talking about basics. I'm not talking about the recalcitrant CRS patient having already all the different procedures, surgeries, treatments. Okay, please, the vial. Now, looking up here, it's a wide space up there. We will check it again with navigation.
I think, Andreas, what is also very nice to see on the outward camera is that you have the endoscope very low in the nose. Is that right?
No,
or is it?
No. I have it very steep. Maybe we can have a camera from outside to show how I'm holding the endoscope. I think that's...
We see it, but the instrument is above the endoscope or below the endoscope?
No. I'm coming from under. I'm coming from under, yeah? Once again, give me this one. I'm coming from under, yeah? Can you see it?
Very nicely, yeah.
Yeah. I think, Valentino, that's a very important thing when you start. When I watch my younger colleagues, I mean, the most important thing is how to hold the club, the endoscope, to make the right swing or the right, movement. If you don't have space, you cannot make your proper dissection. So now I think very interesting, and I think I'm today not perfect because I cannot tell you exactly what is the name of this cell. Once again, give me the navigation, we check it, and we will see. But why shouldn't I not suffering here a little bit?
But could we agree on the fact that it is more important to know where you are and not what the name is? I mean, it is nice. But of course, if you mistake that for the frontal sinus and left it behind, and then you would have the frontal sinus disease yet superior. I think this is the bigger problem, or?
Yeah, I think this new classification, which is published by P.J. Wormald and other experts, I think it helps a lot it's for the better understanding. However, the principle, it's a principle. It's a principle that you have some more structures up there, and these structures have to be removed. And to understand that there could be a Aganasi cell, a cell which is higher, which is going into the frontal sinus. There can be a bulla cell, a suprabular frontal cell. Or maybe these are lamellas, these are spaces, not really cells. It's a basic principle. Now, what I'm doing now, I try to expose the natural ostium of the frontal sinus. And for this, it would be very good to have a through-cutting instrument, but I think we don't have it. Please, can I take an instrument to grab it, the giraffe? Usually, I would take a so-called it's not the right one, but we try to use it. Okay, the same one can be sided, open, but it's not here. Clean, please. Thank you. And now you see step by step, I'm cleaning a bit. Pay attention here, that thinnest part, the thinnest part of the anterior skull base. And usually you shouldn't use too much pressure here. Try to expose it a little bit. Yeah, not doing too much. Okay, I clean it to give you a nice picture. Okay, which instrument? Yeah, now we're having a different instrument. It's a more rough instrument. Maybe it's helpful for opening this. I don't want to use too much power here. I want to do it gently. Okay, so it's gone now. Please, the olive, the upbended olive. And now, step by step, we are approaching, having a nice view here to the anterior ethmoidal artery. You see it's coming out of the orbit along the skull base, entering here lamina cribrosa. It's this reddish structure. It's behind this bony lamellas. Valentino, I think we can see it now nicely, yeah? The ethmoidal artery, yeah? And now I'm going up. I still have the endoscope in the same position. I'm using these upbended instruments to make a wider exposure of the drainage pathway. It's not really an ostium. It's a level where you have your drainage pathway. And that's very important. I mean, there's some change in the terminology of the anatomy of the frontal rhesus and frontal sinus. So, are we really in the frontal sinus? What do you think? I'm not sure. We will see. We are using navigation, please. Where's the appended? So we are looking up. Oh, can you see it? Are we in the frontal sinus, or are we in a septation of the frontal sinus? Can we have
probably an interfrontal cell to stay with nomenclature?
I have to say thanks to the organizers, to Valerie, to Witzke, to Claire, Andrew and Sean, because they gave me this specimen. It's a special one, I think. You know, it's not the easy one, so we have to find the right way in the frontal sinus. What do you think? Do you think that's the way in the frontal? Okay.
Well, on the sagittal it looks quite good.
Giraffe? Yeah, we will see. So let's fight a little bit, not fighting, but let's search for it. Navigation by using your anatomy. And we have navigation, we have as well the endoscope, and we can use everything to find the right way. The best for me is always to see what you do, and seeing is believing. And this helps you a lot, and the good thing is, looking around the corner, go in and, oh, that's a nice opening. Please give me the curette, the thin frontal sinus curette, the thin one. Yeah. Lizzie knows every instrument. I'm impressed. We never worked together before, but this is fantastic. So now I try to expose a bit more, looking around the corner, and can you see it now? There's another opening, a wide opening into the, maybe this is the real frontal sinus, and that's not the medial compartment of the frontal. Now the question is how to expose it without stripping out mucosa. And I tell you, I would do it definitely in the same way during my surgical procedures. Now, very gently exposing the giraffe. Valentino, could you... Yeah?
In a real patient, would you have used the shaver in any of the surgical steps shown so far?
I'm sorry for this, but I think in this case it's not really necessary. I mean, I don't know what to shave away. In a case with polyps, recurrent polyps, I love the shaver. The shaver is for me one of the best instruments because it saves time, it sucks away blood secretion, and you have a straightforward. However, a shaver can be a very dangerous instrument when you don't use it in the proper way, and the most disastrous complications are resulting from the shaver. Please give me the olive. Now, how to open this? I mean, leaving this like it is in a real patient could result in a closure, maybe later on in a mucus retention, late onset mucocele. Now, what I try to do is only cutting away, knipsing away some of the mucosa. It's not opening. Yeah, now. I don't tear. Please don't tear. Don't tear. Make it like this. Go in again. Sorry for the camera. I try to clean it in a second. Okay, now much better. Now going in again. Oops. How much time do we have left, Valentino? 10 minutes, 15 minutes?
About 30 minutes.
30 minutes. Oh, we are
20 minutes to leave some room.
Okay, so now we are looking up. Oh, have a look here. Isn't it nice? We are facing now the frontal and the typical septation. And this is what I was irritated by, because this space, this room, this opening, or this whatever you mean, this doesn't show this septation, which is typically for the frontal sinus. And in this case, I would use a through-cutting up-bended instrument. Give me a up-bended wire. Yeah, perfect. I try to remove this septation, but I'm already very high up and I cannot really reach it with this instrument. I'm spoiled at home because we have this nice instrument which I call a crocodile, which is a through-cutting up-bended instrument, and this is very helpful in this situation. Okay, so a very beautiful view, I think, in the frontal recess and further on in the frontal sinus. Give me the giraffe. I clean it a little bit more, and then Valentino, I think we can highlight a little bit more the important structures which are around. We can discuss further further approaches. So, and it took us now almost 1 hour to get this nice surgery, and this is exactly the time. Okay, so I wouldn't do it in real life. It's just for demonstration and a little bit cleaning, but don't tear mucosa. In case it happens, you can take the mucosa and place it back and leave it where it is, and don't tear it too much. Okay, sorry, I do it here just for cleaning reasons. So, okay. So, now looking up again, we have the anterior ethmoidal artery in a mesenterium. We have here the frontal sinus. We have a cell This is a medial located cell. And when we go here along the anterior skull base, we are turning around the endoscope. We are going into this small little sphenoid sinus. We are coming back. We are looking for the maxillary sinus ostium. And now, at the next step, I would like to show you how you can enlarge the maxillary sinus ostium. Let's assume the patient having a through-cutting Blakesley. The patient is having a semtertride, having severe nasal polyps. The entire maxillary sinus is full. And then I would create a wide opening. And the reason for the opening is not because I'm healing by surgery the patient, but it's to treat the patient with appropriate medication and effective medication. And this means to make a type 2, even a type 3 opening. And here I try to go to the posterior fontanelle, and then I can cut this, but this is really dependent on the individual patient, on the disease of the patient. And you can very nicely open it. And I try to make it in a good demonstration. Okay, so this side, give me the scissor, please. So sometimes you have a small bleeding here. There are some branches of the sphenopalatine artery, and there's a nice paper which is published by Daniel Simen, Nick Jones and Hans-Rudi Briner a couple of years ago about the variation of the sphenopalatine artery and the branches, and you can have even up to, I think, 8 or 10 branches. So it can vary a lot, and if you have a bleeder, you should stop it. Backbiting instrument, and you see now wide opening. This is not routine. This is just for demonstration, and this can help in special patients to get control about the severe disease. And that's very important with local irrigation. And I think Richard Harvey published very nice information about how to handle the patients with the more severe disease in irrigation with steroids in the solution. And we're using this for the last 2 years, and we're having much better results. So now, showing you, this is maxillary sinus. It's a type 3 opening. The sphenoid sinus is almost as well a type 2 opening. A type 3 means a median drainage. At this level, I'm talking about the sphenoid sinus. And going up here, we are facing here the posterior ethmoidal artery. Can you see it behind the bone? And higher up, the anterior ethmoidal artery. We are going high up into the frontal sinus with this other compartment. And I think these are all the most important structures during a classical FES. And now, when you are able to do it, when you are really understood or understanding the basic principle, it's not very difficult to go further and maybe doing a draft type 2B, rare cases, sometimes necessary draft type 3, in the more severe diseased, uncontrolled patient to get access to the inflammation. And then you make a septal window which should expose the other side, the axilla of the middle turbinate, and then you take the whole floor of the frontal sinus. You take a drill. I'm not using the burr, I'm using the diamond for this, and then you make a wide exposure. However, I think there are some indications, but most of the indications are more for this surgical technique which I'm showing you here. And as you can see here, you have the anterior skull base, you have the maxillary sinus, the sphenoid sinus, as well you have the frontal sinus. And this is always my picture I want to show to the younger colleagues. Now give me the Kuhn spoon. Now let's assume, and Valentino, we still have 10 minutes?
We still have some time and a question from the audience.
Yeah, please.
If you would permit.
Very nice dissection. My name is Mr. Reader from Newcastle. Can you show us with the navigation the anatomy of the sphenoid sinus and the structures above it, please, on the scans?
Yeah, I try. Okay, I do it in a second. Here, that's the ethmoidal artery, and when you go here, that's the thinnest part of the anterior skull base. When you go through, you can end up in the skull base and can create a CSF leak. So that's the most tricky area, being very carefully in this area. That's the posterior ethmoidal artery. So let's try to show you with the navigation, and I'm switching back to the 0-degree endoscope.
Perhaps it's also time to say now that when we were looking for the frontal sinus and we had these 3 openings, that you always maneuvered from medial to laterally with either the mushroom punch or the Kuhn, so in order to protect this point of least resistance, which is the lateral lamella of the cribriform plate, in order not to run into skull base. So always maneuver from medial to lateral, so from dangerous to less dangerous. I think this is also very important to mention. And if we look at the anterior ethmoidal, you see how thin the bone is, because here in this specimen you already see it shining through intracranially because it's so thin, so it's more gray than whitish in this area because it's so thin.
Thanks for the question of the colleague, because I'm not sure if we have space behind here. It could be, so let's go behind and let's see if there's still a cell. It's very, it's more the bluish shining, but we have navigation. Please give me navigation. And you see, it's real surgery what I'm doing. I mean, every case is new and you have to do every case in an excellent way. And we see there could be space behind this, and now we are opening this. And yes, of course, there's still space to open, and that's very important, especially in patients having olfaction disorders, and you have still inflammation in this area, Blakesley. And then you should make a proper dissection, especially in the posterior ethmoid to the sphenoid sinus. And in cases what I'm seeing in the revision cases, often the posterior part of the ethmoid cavity is not properly opened. So maybe this is because of the fear of any, important structures like optic nerve, internal carotid artery. Of course, these are important structures, but I think by having the proper teaching and orientation equipment, it shouldn't be a problem. And I think my personal opinion is this kind of surgery is not a surgery you can do just in half an hour. So I'm always surprised, because half an hour is nothing. I mean, for me, it takes me a full house fast on both sides at least 2 hours. And even more, it depends on the case. Think about bleeding. I mean, here we had a situation which was perfect, no bleeding. We used the cotton swabs at the beginning of this dissection, so bleeding was less. No, I'm joking. So, but we are clearing a little bit and now getting more insight. And you see, now with the question, I was a little bit aware about looking more precisely, and there was still space behind. And this is here the posterior ethmoid. And I thought this could be here the posterior ethmoidal artery, but here I'm not sure if we are here in this level. But now, nice exposure, nice opening, wide opening, and now navigation, please. I'm going in. Yeah, we are at the level of the skull base. And this could be here the posterior ethmoidal artery. Here a little bit of septation which I can remove, but very thick bone here. It's very thick, and this here is the sphenoid sinus. We are here now at the posterior wall of the sphenoid sinus. Lower up we are coming to the clivus. Now it must be more medially. It's a very small sphenoid sinus, and here We have the orbit, the apex of the orbit, and I think here is the run of the optic nerve, which is going here further on the chiasm, and lower, a little bit lower, we have the internal carotid artery. So that's so far for me what I could show you. And Valentino, are there any special question? I mean, yes, of course, here the run or outcome of the sphenopalatine artery, which we could dissect. But I think we already got all our aims. And how much time do we still have?
Still some minutes, so I'll ask the audience for questions
Yeah.
to Professor Leunig. Any special things you want to see or you want to have discussed? There's one question, Andreas.
Thank you for the demonstration. It was very nice. But I'm wondering if you're familiar with another technique to find the frontal that I saw it on the internet at some Indian surgeon, which uses he uses the beak, the frontal nasal beak, to find the frontal, and then uses the orbit and the middle turbinate to widen the frontal recess.
Yes.
So what do you think about this?
Yeah, thank you very much. I think, as I stated at the beginning of my surgical procedure, when I resected the antennal process, I mean, you will find and you will have different kinds how you can do it. I think you should always use what's more easy for you. My philosophy is using a very atraumatic way how to do it around the corner. I'm completely convinced about the Graz technique for this disorders I showed you. Maybe when you have a patient having frontal sinus problems after several operations, I have this patient frequently. Sometimes, yes, of course, you have to go to the beak. Maybe you have to use your lamina papyracea for orientation. You have to drill the beak. You have to use the 0-degree endoscope to approach into the frontal sinus, finally ending up in a type 3 opening modified Lothrop procedure. I think and this would be my final comment, my conclusion. I think this short demonstration, what I could show you, demonstrated the possibilities of the different surgical approaches in case you have to do it. However, variations are possible. But the beauty, and I'm citating now Heinz Stamberger, the beauty of FESS and the endoscope is that in most of the cases you can avoid traumatic surgery. And I hope this demonstration could give you some advice, some practical hints, tips and tricks for your daily work for the benefit of your patient. And I hope you enjoyed this dissection as much as we did, and I can tell you, go to the sessions, watch and listen to the experts, and I wish you all the best. Thank you very much, Valentino, for your moderation, and thank you very much for your attention.
Thanks, Andreas. Thank you very much.